Okay, this is it. This is the last presentation for this unit and this course. So, we've talked about all the things that can happen when an infant or child is sleeping. So, what do we do about it? With the technological explosion between the 80s and today, there are a multitude of options for monitoring many vital signs while the child sleeps, most of which you can access in real time with your phone. There are cardiac monitors, cardiorespiratory monitors, pulse oximeters, and respiratory monitors. Some may be so fancy to incorporate all in one. This is an example of at least a cardiac monitor. You can see the EKG pads at the top. A problem I see with this is the wires. You don't want a baby to get tangled up and strangle themselves. It's okay in the sleep lab because we're actively watching them physically, as well as documenting their vital signs. We have special socks that act as pulse oximeters. The second picture is called the Owlet Sleep Sock, and it monitors oxygen and heart rate. My wife and I never used any kinds of monitors other than just a video and audio monitor. Even that thing had a temperature gauge to see if Clara was getting too hot or too cold, and it would have a suggested respiratory problem alarm. We never used any of those. There are special sleeping mats that can record all sorts of respiratory signals like effort velocity, how hard someone is trying to breathe, respiratory rate, heart rate, temperature, and even the sleep state based off movement. Granted, the sleep state is debatable, but everything else is quite useful. Part of the problem with normal parents and babies using vital monitors is artifactual alarms. Sometimes a lot of times, babies are going to move and can make the sensor not work, and the parents freak out every time that happens. And it's just not worth it if there aren't any predisposing factors. What are the reasons to require home monitoring? Well, obviously those who have primary sleep apnea of infancy and patients who have had siblings who have died from SIDS. Premature infants can also on the predisposition list for both infancy apnea and SIDS. If a patient has a tracheostomy, something has happened to that patient to have made them get that procedure. This is either from an apparent life-threatening event or a patient who is terminally disfigured for properly breathing. Tracheostomies are also a last resort for patients who have failed every respiratory treatment. Bronchopulmonary dysplasia is the disorder that premature infants have, specifically severely underdeveloped respiratory anatomy. These patients are very sick, have been on ventilators, and have received high flow rate oxygen for long periods of time. You want alarms on all these devices in case the device quits working. Again, patients whose mothers have abused drugs during pregnancy should be monitored. For patients who have been diagnosed as high-risk potential for SIDS, home apnea monitors may be medically required. It really depends on what insurance will cover and what the physician prefers. Typically, one or more conditions must be met. These include life-threatening events, which is defined as requiring mouth-to-mouth resuscitation or vigorous stimulation. The patient could be diagnosed as having clinically significant apnea, where apneas may be up to 20 seconds or longer, and if less than 20 seconds, if it's accompanied by cyanosis. Symptomatic preterm infants, which continue to have pathological apneas when they should be healthy enough to go home, could technically be sent home as long as they are continually monitored. Also, siblings of one or more SIDS victims is another criteria to qualify. There are some of the typical insurance requirements for home infant monitoring. Documentation of the episode which led to the diagnosis must be included with the claim, meaning medical health professional documentation. The physician that diagnosed the infant as having clinical significant apnea must prescribe the monitor, and it may be helpful for them to know which monitors are covered by different insurances. If the monitor is needed for longer than 12 months, after which the instances of SIDS dramatically reduces, continuing necessity should be documented by a report from the attendant physician and reviewed on an individual consideration basis. This would be more for sleep apnea of infancy. Charges for accessories necessary for effective functioning of covered equipment, as well as charges for adjustment, repair, and replacement of the device, are all eligible for benefits. Remember, the DME company is the party responsible for all the devices and accessories not dispensed at a pharmacy, like CPAP masks and other equipment, oxygen tanks, concentrators, catheters, and other durable medical equipment, hence the name DME. I've never personally met anyone who works at a DME company or someone who's connected equipment up at home, but the education they provide is not very much. It's negligible. It is always advantageous to follow up after the DME company has done their part to make sure everything is set up correctly. Typically, the DME has some core responsibilities. These may include ensuring that there is an electrical backup for when the power goes out. You still need these devices to function. They should give advice and make sure the environment is suitable and the monitor does the job. They should include training sessions, especially in how to use the monitor. They may include a CPR educational session, but I doubt it is anything that would award the parents like a CPR card. All these charges should be included in the initial rent fee or purchase agreement. Personally, I think it's a miracle when all these elements between the doctor, DME, and insurance communicate and get things right the first time, because it rarely happens. Alarms on these devices should be set to alert the caregiver for the following issues: pauses or apneas in breathing, brady or tachycardia, a low oxygen to saturation when sensors are not attached, and when there is a low battery. Duration of apneas that trigger the alarm are preset by the company and is designated by the physician. For instance, an alarm would only sound if the apneas were longer than 10 seconds. That can be set. When an alarm does sound, the first thing to do is make sure something wrong is happening. There are so many things that can cause artifactual signal that you have to make sure everything is plugged in. So first, check the baby. Then check the connections. If the baby is not breathing, unresponsive after the stimulation, striking the foot, or calling out, you need to call 911 and begin CPR. Although it is almost impossible for some people to remember in times of distress, it is helpful to document the occurrence and the description of the situation. For instance, what position was the baby in? What was the room temperature like? Were there loose items in the crib? Monitors are a great source for information when it comes to how a baby is doing. However, they do not guarantee a positive outcome in the case an infant has, if the infant does have an apparent life-threatening episode. It does, however, allow for quick action and the potential for life-saving techniques to at least give the patient a chance. That's all for pediatric respiratory stuff. Try and find the patterns in these disorders, which are similar and how are they different. That's one way that you can keep up with all the nuance and subtleties for each of these disorders.